College of Pharmacy, slot number SYCCON or XS48004. Rifa Eben Joel, Chair in College of Pharmacy, slot number SYCCON or XS48004.
Am I audible?
Yes, you are.
Is my screen audible?
Yes, dear, your screen is visible. You can start presenting.
Thank you. Ka. So good evening, one and all present here. So I'm going to present a case on psoriasis. Excuse me, my case. Okay. So let me introduce about what is psoriasis. So psoriasis is a chronic skin condition caused by an overactive immune system, and usually the symptoms are flaking, inflammation, and thick white, silvery, or red patches of the skin. So here is the patient details that a 50-year-old male patient was admitted on a given date at dermatological ward with complaints of multiple erythematous cover ulcer plaques over his upper and lower limbs and trunk for 4 months, and he has itching and pain in the skin. So let me introduce about his family and personal history. And he is an alcoholic, and he does not have any previous allergies. He already have hypertension and diabetes mellitus type 2 for about 13 years. On examination, the patient was calm, conscious, and oriented, and his bilateral respiratory system, CVS, and per abdomen CNS are very clear and it's very normal. And his vitals also very normal. And he have aspartate aminotransferase, that is, which is SGOT, a little higher level, and these are the lab investigation. And by this assessment, usually by subjective, we come to know that he has diabetes mellitus type 2 and hypertension, and he has multiple erythematosis and plaques. By objective, we come to know that he has increased fast blood sugar level and random blood sugar level, and he has increased cholesterol level and very low density lipoprotein level, so that he has hypertension and diabetes mellitus as well as psoriasis. Based on the subjective and objective, we come to know that he has the psoriasis with DM2 and HTM. So here are the treatment regimen. First, coming to the tablet acitretin, it comes under the category of retinoids, and it acts as a anti-inflammatory agent and anti-proliferative agent, which decreases the dermal inflammation and reduce scaling. And tablet coming to the tablet ranitidine, and it is the H2 receptor antagonist, and it reduces the gastric acid secretion. And coming to the injection cefirone, which is also known as ceftriaxone, and it is common antibiotic, which comes under the category of cephalosporin. And injection ondansetron comes under the category of anti-emetic drugs to prevent nausea and vomiting induced by chemotherapy, and it blocks the 5-HT receptors. And coming to the tablet telmisartan, it is angiotensin 2 receptor blockers, which binds with angiotensin 2 to angiotensin 1 receptor, and it acts as smooth muscles and adrenal glands, and it causes vasodilation. And coming to the tablet ursodeoxycholic acid, it is also known as UDCA, which acts as a secondary bile acid. And tazarotene gel comes under anti-psoriatic agent, and it actually modify the gene expression and treat the plague psoriasis and facial acne vulgaris. And neosalic ointment comes under corticosteroid, and it is antipyretic, antipyretic and anti-inflammatory. And protar ointment comes under keratolytic agents, and it is usually used to remove scaly patches of the skin. And Remoise cream is used as a moisturizer because to reduce the dry skin. And injection insulin is used as a fast acting insulin where the patient has diabetes
With
mellitus
more.
type 2. So to reduce blood glucose level, we use this. Then so discharge medication also given. So drug-based counseling also given. So lifestyle modification, the patient is advised to take daily baths and add sea salts to the water and soak it and avoid harsh soaps and exposed to sunlight and avoid psoriasis triggers and injury, stress, smoking. They are all avoided and avoid drinking alcohol. Thank you, sir.
Thank you, Rifa. Now over to Dr. Nagarjuna.
Your presentation is good one.
Thank you.
So what do you know by psoriasis one?
The psoriasis is an autoimmune disorder, so it may be um, by stress or genetic agent, or sometimes it is the hyperactive of T cells, and because uncontrollable cells grow, and we will experience the scaly patches in our skin, sir.
Tell me any few environmental factors ma, which will cause psoriasis.
Sir, it may be sometimes chemicals and pollutants.
Okay.
So then sometimes temperature may cause this, climate, weather condition.
Climate, stress, alcohol, these are all comes under environmental factors only.
Yes,
So next one, tell what do you know about genetic factors also is there? No?
yes, sir.
Tell any few factors comes under genetic factors which will cause psoriasis.
Sir, in genetics, if suppose in family, if somebody has the psoriatic problem, so it may be transferred through genetics or some, it may be spread through.
Okay, one next. What is balneotherapy? Do you know
Sir,
balneotherapy?
sorry, sir, I have no clear idea about that.
Okay. Seema, in non-pharmacological treatment, is there any role for moisturizers like emollients like that? Is there any role in this case?
Because, yes, sir, because here itself we use more moisturizer and Remoise cream is also acting as moisturizer in this case. So preventing dry skin is very important in this case, sir. So it maybe we can see many flaky skins and scaly skins in our skin. So we may use that moisturizer, sir, to prevent dry skin and itchy skin.
Okay. What is the first line therapy, ma? Here, first line means both topicals are there, systemics are there. Do you know about topical or systemic first line drugs? If you know, means what are those?
Sir, I may think this proteroid and keratolytics act as a first line therapy and
Okay.
corticosteroid,
Okay.
then anti-psoriatic agent that is some gels like tazarotene gel. So they are act as a main part in the topical agent.
Okay. Okay, my last question. In diagnostics of psoriasis, there is one index is there, PASI. What is PASI? Do you know about PASI?
Sorry, sir.
It's nothing but as a psoriasis area and severity index will be there. It is nothing but as to determine the extent of body surface area, how
Okay,
the
sir.
erythema will be there. Okay.
Okay,
Overall,
sir.
your question and answer session is good one. Good.
Thank you. Thank you so much.
Thank you, Rifa. You can stop sharing your screen now. Shout out to my juniors. Well done, guys. And now, next to the participant, Jason Fernandez Joachim from Karavali College of Pharmacy, slot number SYCCON RXS48005. Jason Fernandez from Karavali College of Pharmacy, SYCCON RXS48005. Jason, are you there? Okay, okay.
Shall we move to one more?
Yeah, sir. Jason, if you're facing any difficulties, you can present the next time, like after the next participant. Shall we then?
You can start one more.
Okay, sir. Okay. So the next participant, Puna Deepak Kumar from KVK College of Pharmacy, slot number SYCCONRX S48006. Deepak Kumar from KVK College of Pharmacy, slot number SYCCONRX S48006. Deepak, I think Deepak is also haven't joined us. Okay, guys. If Jason and Deepak are ready to present, please comment in the comment chat box. And to our next participant, Yogesh from the Erode College of Pharmacy, slot number SYCCONRX S48007. Yogesh from the Erode College of Pharmacy, slot number SYCCONRX S48007.
Hello, am I audible?
Yes, you are.
Hello, is it my screen is visible?
Yes, yours is visible. We can start presenting. Your time starts now.
Good evening, I'm Yogesh. Today I'm going to take a case presentation on Bell's palsy left low motor neuron with type 2 diabetes mellitus and hypertension. A 45 years old male has admitted in male medical ward with the chief complaints of left side face weakness for 1 week and vomiting for 4 episodes and difficulty in closing of their eyes with giddiness. So the patient is already suffering from systemic hypertension and type 2 diabetes mellitus, and the past medication history is metformin for 500 mg and amlodipine for 10 mg, which is irregular. The vaccination history is immunized up to age, and surgical history, the patient is already with facial nerve decomposition surgery done 2 years back. The patient is smoker and alcoholic. Under objective, the patient is conscious and oriented. The pearl cyanosis, ictus, and edema are negative. Under vital signs, the blood pressures seems to be abnormal because the patient is already suffering from hypertension. Under laboratory investigation, I have taken hematological test, which seems to be normal compared to the normal value. And under liver function test also seems to be normal compared to the normal value. But here, under blood sugar test, the fast blood sugar, post-parietal blood sugars, randomized blood sugar, and HA1C test seems to be abnormal compared to the normal value. Now, for physical observation, the facial dropping on left side and dropping a corner of left eye and left mouth. I have also taken a seven cranial nerve testing in which the left side of actions of faces are incomplete compared to the right side. I have also taken House Berkman facial nerve scale, which shows fourth grade as moderately severe. Under functional status, the patient has a difficulty and slurred speech, and he's making effort for talking. So above diagnosis and subjective, I have assessed that the patient is suffering from Bell's palsy, left low motor neuron with type 2 diabetes mellitus and hypertension. These are the basic assessment for the patient. And under drug management, I have given prednisolone 5 mg, paracetamol 500 mg, carbamazepine 200 mg, ranitidine 50 mg, metformin 500 mg, and amlodipine 10 mg. Under prednisolone, I have used steroid trapping method in which the steroid doses are decreased day by day. These methods are used for the to give a gap for the adrenaline gland to produce cortisols. These are the discharge medication for the patients.
Treatment chart.
And under disease-based counseling, the Pill's palsy is basically a unexpected episode.
1 minute more.
Hello.
You have 1 minute more. Go for it.
Um, it is unexpected episodes, weakness and paralysis of paralysis, which can leads to pain and difficulties on one side of the faces. And we can assess physiotherapy for the patient for facial nerve. These are drug-based counselings. And under diet-based counseling, the patient should take a balanced diet to overcome and recover from their health. And the patient should always hydrated and avoid the caffeine contained beverages. And the anti-inflammatory, and they should take anti-inflammatory food. The patient should have a sufficient amount of vitamin B12 and zinc for the functioning of nerve.
Thank you, Jason. Your time has come to an end. Thank you. And over to Dr. Nagarjuna.
Yogesh, your presentation is nice, man.
Thank you, sir.
Okay, the question here is, what are the complications for Bell's palsy? First, tell me, what do you know?
So am I audible?
Yes, you are audible. Tell.
So basically, Bell's palsy is a basic disorder which is come under the facial muscle damage and seventh cranial nerves. And the basic complication is eye infection and ulcers.
Is there any exact causes for Bell's palsy?
Sir, basically it is caused by diabetes, myasthenia gravis, and viral and bacterial infections.
No, I'm asking that, is there any exact cause? Is there or unknown cause?
No, sir. Basically, it is caused by myasthenia gravis.
Okay, next, open once a treatment chart.
Yes, sir.
Okay, how the prednisolone is going to be helpful in Bell's palsy?
Sir, it can give a pain relieving from the for the patient, sir, and inflammation.
How the tell me the mechanism of action of carbamazepine.
Sir, I can't audible. So it is basically anticonvulsant agent, which can basically use for neurological pains.
Okay, what are the possible risk factors for this case, Bell's palsy?
Sir,
What are the risk factors for the possible risk factors for Bell's palsy?
so basic
Hello?
risk factors. So basic risk factors are viral and bacterial infections.
Okay, last question, ma'am. So
Yes, sir.
Bell's palsy is there now. Apart from that, we are having this person having diabetes, hypertension also. Can
Yes, sir.
you any complications which will arise from diabetes mellitus?
Sir,
Complications which will arise from diabetes mellitus.
so diabetes mellitus can basically causes neurological imbalance like that and also.
Okay, thank you for participating, ma'am. Over to Jennifer.
Thank you. And to the next participant, Jason is given a chance now. Jason Fernandez from Karavali College of Pharmacy, slot number SYCCON or XS48005. Jason Fernandez, slot number
Hello.
SYCCON or XS48005. Yes, yes.
One second.
Yogesh, you can stop sharing your screen.
Is it visible?
Yes, it is. You can start presenting. Your time starts now.
Good evening, sir. Today I will be presenting my case presentation on type 1 respiratory failure differentiation syndrome in patients with acute promyelocytic leukemia. So a 33-year-old male patient was admitted in medical oncology ward on 2nd of December 2023 and discharged on 1st of January. He had arrived with the chief complaint of vomiting, weakness, and headache, since also arrived to continue his chemotherapy. 33-year-old male on admitted on December and discharged 1 month after. Complaints, weakness, vomiting, and headache. Past medical history, he had recently diagnosed with the acute promyelocytic leukemia with interparenchymal hemorrhage in bilateral cerebral and right cerebral. Past medications include Levipil. There was no family history of the same disease as well as no allergies found. His respiratory rate, abdomen, and other all local examination of the brain, MRI plain and contrast both were done and found that he had a hemorrhage in the bilateral temporal lobes, bilateral frontal and parietal lobes, right? Hemorrhage in right cortex and right cerebellum, largest seen in the right cerebellum of 2.4 to 2.3 centimeters. Chest X-ray bilaterally scattered inhomogeneous opacities noted in the right and lower zones and left middle zone. This chest X-ray was taken after the differentiation syndrome, the initial one. General information, blood pressure was found to be normal, respiratory as well as respiratory system, no fever, sugars and SpO2 was normal. But on the second day of on third day of admission, you can see that is hemoglobin is decreasing as well as the platelets. But on the time of the admission, his hemoglobin was about 3. Other departments, so we do not find. I was not able to find the data for it in short time. Next, SOAP analysis, as I said previously, objective evidence as well. So as you can see, there is a hemorrhage in the cerebral, the parietal lobes, and the cortex over here. And this is the lung chest X-ray after the differentiation syndrome. From the subjective and objective evidence that the patient diagnosed with type 1 respiratory failure differentiation syndrome, myelocytic leukemia. So treatment goals were providing respiratory support, managing differentiation syndrome promptly with corticosteroids, monitoring and managing pulmonary infiltrates, ensuring hematological stabilities, and managing arsenic trioxide toxicity. That is primary treatment, offering psychological support and educating the patient and family for optimal outcomes. Disease specific to prevent the progression of disease and to prevent further complications. Drug chart, tab Levipil, levetiracetam. This was given in order to as a preventive measure of seizures or throughout the seizure. In order to prevent it, we had given him levetiracetam. Emisette for his vomiting. Pan, due to a large amount of drugs that we were given, there was a high risk of getting stomach ulcers. Arsenic trioxide and the fourth one, cap atra, that is acid tretinoin, is the primary treatment for the APML, that is acute promyelocytic leukemia. You give it as a differentiation syndrome, that is this chemotherapy these two differentiation agents. We also give him a chemotherapic agent that is daunorubicin.
1
That
minute
is an
more.
anthracycline based treatment. Other drugs were given as a prophylactic treatment to prevent injection, since patients with the APML are immunocompromised patients. Next, diazepam, glutentus, dexa. These were given during his differentiation syndrome. In this, there will be difficulty in breathing. There will be inflammation throughout the body. There will be for these purposes, these two, glutentus and dexa are given. Injection nucine, that is filgrastim, is given to increase the white blood cells in his body. This is the progress chart from start to end. Has in the 12th day, he developed breathlessness, that is the differentiation syndrome, having fever of 100 with the Krebs. For that purpose, all the antibiotics were started as prophylactic. Throughout this differentiation syndrome, we were given
Thank you, Jason. Your time's up.
on ventilation.
Thank you. And over to a judge.
Jason, your case is good. And open once main slide, title slide.
Yes, sir.
Okay. What do you know by leukemia? Types also there.
Leukemia
What
is
types are?
yes, sir. Acute lymphocytic leukemia, acute myelocytic leukemia, and chronic lymphocytic leukemia. This acute promyelocytic leukemia, it comes under acute myelocytic leukemia. It's a subtype which is a little different from acute myelocytic leukemia. This has a differentiated acute promyelocytic leukemia. In this, there is a tendency of bleeding and disseminated coagulations throughout the body, whereas in acute promyelocytic leukemia, there is no bleeding seen.
Okay, you told that one more drug, daunorubicin, is there, no?
Yes, sir.
Okay.
Could you repeat the question, sir?
You mentioned one more drug in treatment chart, daunorubicin.
Yes, sir. Yes,
Can
sir.
you tell
Anthracycline.
what it will work?
Sorry, sir.
How it will going to be work?
It acts on topoisomerase 2, sir. That is during the cell cycle. It will prevent like the cells will be supercoiled. So topoisomerase, as you inhibit the topoisomerase, that's what you say, differentiate the cells has the cell. I mean the prevents
what
it
is the
from differentiation.
okay? What is the
Sorry, sir.
possible risk for respiratory failure?
Respiratory
What
failure, sir. Yeah, so the reason was actually atra, that is acid, tretinoic acid, and as well as arsenic. These two are called as differentiation.
The chief complaints of red rashes scattered over the upper lip.
Hello, hello,
Hello,
hello.
tell man.
So acid, tretinoin as well as arsenic, these are differentiating drugs. That means that the promyelocytes are differentiating into WBCs.
Okay. The last question.
Sudden
how the role of peptides is there, no? What is the maximum
yes,
dose
sir.
of peptides in a day?
Maximum dose, sir. Maximum can be around 120. For this patient, there was also Rantac as well as pantoprazole, sir.
No,
Both were
I'm
there.
about piperacillin tazobactam maximum dose in a day.
Piptaz, sorry, sir. Piptaz maximum is around
Okay, 12 to 18 grams we can consider as a maximum dose for piptaz.
yes, sir.
So
For this patient, we could not give has he had a promyelocytes of 80 to 90%. This is level 4 APML, sir.
okay, what is the tramadol dose? Only tramadol dose.
Only tramadol, sir. So 50 mg, sir. And
Okay,
for the ultraset, it is 37.5, but normally it was 50 mg.
Okay, Jason. One more last question.
Yes,
what are the possible side effects of levetiracetam? Exact side effects.
Could you repeat it again?
What are the exact side effects of levetiracetam?
Side effects of levetiracetam. In this patient, we had seen even breakthrough seizures as well. That one episode, he was on levetiracetam, so that may also be a ADR for this. Others include there is dizziness, not very prominent one, vomiting as well as it may also induce seizures for some.
Okay. Overall, your presentation is good, man. Good.
Thank you, sir. Thanks.
Thank you, Jason. And next participant, Deepak Kumar from KVK College of Pharmacy, slot number SYCCON RXS48006. Deepak Kumar from KVK College of Pharmacy.
Good evening, everyone. My name is Deepak Kumar Punna. I am from KVK College of Pharmacy. My case is about diabetes gastroparesis. The 58 years old male patient has been admitted in the hospital with nausea, abdominal pain, early fatigue, and post-diabetic food loss, and is suffering with vomitings since 5 days. And his past medical history is type 2 diabetes, hypertension, dyslipidemia, and depression. His past medication history was metformin 1000 mg, insulin, amlodipine 5 mg, simvastatin, and ceftaroline 50 mg. Coming to the lab, his fast blood glucose level is 220 mg per dl. His HbA1c level is 9.5. His serum creatinine level is 1.3 mg per dl, and his hemoglobin is 12 grams per dl, and protein is 9 mg per dl. Or sorry, 9 grams per dl. His other investigations are lab investigations are done. His mild gastritis has been noted, and gastric emptying study has been done. Delayed gastric emptying time is 120 minutes. Based on subjective and objective evidence, we have diagnosed the patient is suffering with diabetic gastroparesis. Coming to the pharmaceutical is symptom relief, gas, esophageal relief, prevention of complications, long-term management and prevention, psychological support as suffering with depression. We have mentioned it in the past medical history, a personal education, and environment, and monitoring and following, and then dietary plan and lifestyle modifications. Coming to the measurements, sir. Metformin 1000 mg 30 units are given BC a day, amlodipine 5 mg is given twice in a day, ceftaroline 50 mg is given twice in a day, metoclopramide my 10 mg is given 50 mg. J for aldosterone is given 4 mg. Distinable pantoprazole 40 mg is given a day, and metronidazole 500 mg infusion is given 5 a day. We have treatment of the changes and medication and endoscopic therapy and surgeries such as gastric bypass surgery and pyeloplasty and gastroenterotomy. Done with my presentation, sir. Hello, is it audible? Done with my presentation.
Yes. Yes, it is audible. Devakumar.
Sorry?
We can audible, man.
Sorry,
Hello?
sir. Yes, sir.
Your presentation is completed.
Yes, sir.
Over.
Yes, sir.
Okay, man. So your title is diabetic gastroparesis, right?
Yes, sir.
So what is the reasons for causing the diabetic gastroparesis?
The main reason is diabetics, sir.
Okay, what is the significance of HbA1c?
Sorry?
What is the significance of HbA1c?
HbA1c.
What is the significance of HbA1c?
This mainly it is a diagnostic test which is used to determine the blood glucose in the blood.
So do you know what is the significance of serum creatinine?
Related to it is a waste product related to
See, your voice is unable to audible. It is like a cut.
sorry.
Your voice is unable to audible. Can you tell me once again what is the significance of HbA1c?
Significance of HbA1c. The HbA1c is a diagnostic test which is used to determine the blood glucose level.
Okay. Do you know about diabetics index score?
No, I don't know, sir.
So you are mentioned insulin 30 units are there
Sorry?
in open treatment chart once.
Okay.
See, you mentioned injection insulin 30 units are there. On what basis they chosen 30 units?
Actually, they was monitoring of the patient. The patient is suffering as his blood glucose level is somewhat above. In that case, they are chosen like that.
Okay, man. Tell me any few counseling points regarding lifestyle in this.
Sorry?
Can you
Hello?
say few points related to lifestyle?
Yes, I mentioned in the patient counseling that weight loss for the patient is to include protein-rich meals in the diet and avoid alcohol. Is as is suffering with the gastroparesis, we have mentioned that patient or we have suggested a patient to eat small, but we, we have to take sleep after 3 hours of these meals.
Okay, man. Last question. If the patient having gastroparesis, how we can know this patient is having diabetic gastroparesis?
Sorry, sir, can you please repeat it again?
See, if the patient having diabetic gastroparesis, how we can know that patient is having a diabetic gastroparesis?
Okay. How can
Am I
we?
audible?
Yes, sir. If the patient having gastroparesis, how can we know that he is having gastroparesis? Like you are saying that
Yes, right.
we can we can conclude it by two tests. One is like H1 HbA1c. Other is
Okay. See, we can see the person having any digestive symptoms are there.
No.
So we are
There is
how
a
we see.
there
I
is
am
a
asking the see. Actually, we are unable to hear your voice.
okay. Wait, please wait. Please.
Okay, man. Anyhow, okay. Nice presentation. Good.
No. Actually, I am mentioning here the gastric emptying time is delayed here. So you can see here.
Okay. We want this one only. Delayed gastric emptying time. Okay, man. Good.
This is somewhat network
Thank you,
issue.
Deepak.
Okay.
And to our next participant. Before that, just a kind information for everyone. Kind information, everyone. Presentation for Zone T has begun. Make sure you are in the right place. Check the participation group so that you can check whether you are in Zone T or Zone S. This is Zone S. So the people who are to present in Zone T, make sure to join in that link. And that's it. Make sure to confuse the conditions right. Let's move to the next participant. Jnanishu Kumar from TVM College of Pharmacy. Slot number SYCCON RX S48008. Jnanishu Kumar
Yes,
from
ma'am. May I
TVM
audible,
College of
ma'am?
Pharmacy. Yes, you are audible. You can
Yes, ma'am. May I
start
audible?
sharing. Yes.
Yeah, ma'am. I am sharing my screen. Whether my screen is visible, ma'am?
Yes, your screen is visible. You can start presenting. Your time starts now.
Thank you so much. Myself, Ganesh Kumar from TVM College of Pharmacy. I am going to explaining about a rare case that is FAR syndrome. The incidence rate of this is 1 in 1 lakh, 10 lakh peoples. And there is no treatment for the FARS syndrome. The FARS syndrome and the FARS disease are different. Means FARS syndrome is a group of disease, whereas FARS disease is due to only one cause, whereas FARS syndrome is due to many causes. So here the FARS syndrome is mainly due to hypoparathyroidism. So what happens in case of FARS syndrome means there is a bilateral striatopallidodentate calcinosis. Means the basal ganglia parts, that is striatum, pallidum, and dentate nucleus. These are the main parts of the basal ganglia. So in this area, the calcium may get deposited. So due to deposition of calcium, the patient may shows the motor abnormalities such as rigidity, and seizures. These are the main symptoms of the FARS syndrome. The main cause for the FARS syndrome is there may be a metabolic disturbances, or there may be underlying illness such as that is hypoparathyroidism, or there may be an infection such as meningitis. So what is meant by hypoparathyroidism? Hypoparathyroidism is nothing but our body is unable to produce sufficient amount of parathyroid hormone. So what is the use of this parathyroid hormone? Parathyroid hormone, which is responsible for maintaining the minerals, that is calcium and phosphorus, by absorbing the calcium from the bones, that is osteoclast, and by absorbing the calcium from the distal convoluted tubule, and it can also helpful to excrete the phosphorus from our body. So it is very responsible. So in case of any hypoparathyroidism, it will not work. Means the parathyroid hormone will not secreted, and this if it is not secreted means there is a low secretion of calcium, and there is increased absorption of the phosphorus in our body, so which can cause us a ectopic disposition of phosphorus and calcium. We know that if there is an imbalance in any two electrolytes or any two minerals, that can lead to the ectopic deposition. So this in same condition here, due to abnormal concentration of calcium and phosphorus, or due to hypoparathyroidism, what happens in the basal ganglia, means in the bilateral, means on the both side of the brain, there will be deposition of the calcium can be seen. So here we go with the case. The subjective, the name of the patient is XYZ, age is 20 years, that is a female patient, admitted to general medicine, allergies is nil known, and the weight of the patient is 49.9. So when come to subjective, a 20-year-old female patient was admitted to the female medical ward with a chief complaints of blurring of vision, right eye since 2 weeks. When come to past medical and medication history, she is a known case of FAR syndrome secondary to hypoparathyroidism, referred to in view of right eye cataract, planned for surgery. There is a history of epilepsy, that is a pseudo seizure at 10 years of age. She is on tablet Levipil 500 mg and carbamazepine. History of hypocalcemic seizures, that is the serum parathyroid hormone is less than 1.2, and she started with tablet calcium and calcitriol. So now we are going to the personal history, that is diet is mixed, appetite is reduced, sleep is normal, and bowel and bladder are normal. So here came with the objective. On examination, her BP is 96/70 mm of Hg, pulse rate is 80, the respiratory rate is 20 cycle per minute. And CNS, CVS, and these are all normal. So here they did two important tests, that is Triassius sign test and Chopsticks sign test. Here the Triassius sign test can be done by the BP, the BP BP can be BP monitoring machine. With the help of the BP monitoring machine, they can tie into the arm and they can elevate the pressure more than systolic pressure. So they will get the excitability of the muscles, which can indicates that there is a calcium depletion, means there is low concentration of depletion. We know that if the calcium concentration in our body is low, means there is hyper excitability, means excitation will be more. And Chopstick sense, this can be done by exact 2 centimeter from the ear. We can tapping from the finger can be done, so which leads to excitation of the facial nerve, which indicates that there is a hypocalcemia. So these two signs are did in order to confirm whether there is a hypocalcemia or not. So when come to advice, they
1
have
minute
given for
more.
CBC biochemistry and calcium, phosphorus, and parathyroid hormone level in order to confirm whether hypoparathyroidism is there or not. And CT scan is done in order to identify whether the calcium deposition in the bilateral striatopallidum is there or not. So these come to the laboratory parameters. The serum calcium is also decreased, serum phosphorus is increased, serum magnesium is decreased, and parathyroid hormone is also less than 1.2, means decreased. And these are all the other parameters. So when come to other investigation, the CT scan, as I like said, that there is a bilateral calcium deposition. Audiogram is done in order to test whether the means hearing ability of the patient. 2D echo done in order to check the means ejection fraction, means ability of the heart to pump the sufficient amount of blood to the different parts of heart. That is lower ventricular ejection fraction is 50%, that is normal. USG neck normal study, ophthalmology showing that cataract, means clouding of the lenses. So here we going with the differential diagnosis. What is the need of differential diagnosis? Means the hypoparathyroidism, the reason for the
Thank
hypoparathyroidism
you,
we should know.
Ganesh.
So
Thank you, Ganesh. Your time's up.
yeah.
And it's over to a judge.
Ganesh, you almost all covered for more time for introduction part and up to diagnostic only. So that
Yeah,
is
sir.
also good presentation, nice introduction.
Yeah.
So is there any exact cure for Fahar syndrome?
No, sir, there is no cure for FAR syndrome, sir. Only the symptoms the patient suffering, that only can be treated.
Okay, can you share me once treatment chart?
Yeah, sir, definitely. This is the treatment chart, sir.
See, can you explain about injection calcium gluconate in this case? What role does it is going to take place?
Calcium gluconate, sir. As if there is a decrease in calcium in our body, means there may be means the membrane stabilization will be decreased. Means there is no proper membrane stabilization. So in order to do membrane stabilization, calcium gluconate is sufficient, sir. But here the intervention is along with calcium gluconate, insulin should be given, sir. Because if insulin should not given, means the potassium channel is also always open. So if potassium channel is open, means there is no sufficient influx of the calcium into the body, and there is no mechanism, means membrane stabilization will not happen, sir. So this is one the intervention. And another one is, if in case of phosphorus is elevated to the in this patient, means the phosphorus binders are very necessary, sir. Because if phosphorus levels are not controlling in this patient, means this again can cause us again ectopic, means again deposition of phosphorus products, again
Okay,
elevates the conditions.
good Ganesh. And one more question from regarding treatment. How the fluoxetine is going to be helpful here?
Fluoxetine, sir. Fluoxetine is a selective serotonin reuptake inhibitor, sir. Actually, I said that the calcium deposition is more commonly seen in bilateral striato, means basal ganglia. So if it is affecting in the basal ganglia, means there we have different parts like amygdala, pallidum, striatum, and substantia nigra. Substantia is very important for maintaining our motor activities and our behavior and our emotional effects, sir. So due to this, there may be chances of occurrence of anxiety, or there may be Alzheimer's disease, like that, sir. So in order to prevent these complications, fluoxetine is very helpful, sir.
Okay. Last question, Ganesh. Go to tell me about lifestyle. What you mentioned there. Is there any prevention steps are there? How to
Yeah,
control
sir.
or how to manage?
Lifestyle modification is, it is not due to genetic, sir. If it is genetic, means Genetic causes are like gene mutation, that is SLC2A02, XPR1, and PDGF. These are gene. If gene mutations means we can, if it is autoimmune means we can treat it, but it is not genetic. It is secondary diseases. So we should main concentrate on hypoparathyroidism. So in hypoparathyroidism, there is a decrease in calcium, and there is a elevation in phosphorus and decrease in magnesium. So we should give calcium supplements along with the vitamin D supplements also, and we should give magnesium rich foods, and we should avoid phosphorus containing foods, and regular exercise can help. Regular exercise and stress management can help to prevent from stress and anxiety, sir. And the calcium calcium foods such as the dairy products, milk, these also. And when come to phosphorus containing foods, there may be almond and pumpkins. This should be given, sir.
Okay. Overall, your presentation is excellent, Ganesh. Over to Jennifer.
Yes. Yes, thank you.
Thank you, Ganesh. It was interesting case, wonderful presentation, and crystal clear answer. Good effort, appreciated. And next
Thank you.
participant, uh, for an emergency purpose, we are just shuffling this slot. Our 14th participant, Shwati, will be presenting next. Sorry for the inconvenience. Next participant, Shwati from Swami Vivekananda College of Pharmacy. Slot number SYCCONRX S80014. Shwati from Swami Vivekananda College of Pharmacy. Slot number SYCCONRX S480014.
So everyone, am I audible to everyone?
Yes, you're audible. Your screen is also visible. You can start presenting. Your time starts now.
So this is a case presentation of a pharmacist intervention over a accidental injury. So one of the patient, a 42-year patient, comes with an injury of lower limb where he got accidentally cut by iron gate during the preparations for some rituals. So the patient was coming to the government hospital priorly was taken a treatment in some unknown clinic. So he was coming to the government hospital where we are doing internship right now, and his known case of type 2 diabetes and systematic hypertension, and as well as DLP as well. But the known history is like he's an alcoholic since on and off mode. He's using on alcoholic only on and off mode, and his laboratory parameters were like quite potential and good. The only thing which is elevated is like WBC and CRP, which are all normal during the accidental injuries. So what is it? Before we are going into before due to the heavy hectic flow of the patients in the OP, the doctor has cleared as a primary diagnosis, which includes a subcutaneous rupture and a peripheral neuropathy, which is since like the patient also complained a burning and tingling sensation over the lower limb. So the doctor classified it as a peripheral neuropathy. And secondary diagnosis include it might be also a right lower limb wound infection. And what is a pharmacist intervention? So after the doctor has prescribed some medications, we as a took some historical review what the patient has done after the injury, why you have taken long this many days to come. So the injury has happened 5 days back, and our patient is coming now at let's say 20th the injury, and 25 is coming on. So he has taken his usage of medications previously, and we found out that he has been using linezolid. Linezolid is a topmost antibiotic drug which will be given only during the vancomycin resistant or some multi-therapeutic drug failure operation cases only. So an unknown doctor has prescribed him a linezolid drug, at the patient during the presentation also he has said he has been feeling a right lower limb chest pain as well. So this chest pain might be as area of right linezolid, but the patient doctor didn't know about it, and he was about to prescribe atenolol for the chest pain and also propranolol for the prophylaxis treatment. So when we have reviewed the patient case sheet, and we found out that linezolid was given him previously, so the these atenolol and propranolol prophylactic drugs were changed into ceftriaxone, which is a third generation cephalosporin, which works by inhibiting the cell wall synthesis, bacterial cell wall synthesis. It was given as a start medication, and for the 5 days he was advised at the cefixime. So along with this, for GI prophylaxis, ranitidine was advised, and diclofenac 50 mg for SOS only on pain he should be having on it. And for wound healing purposes, the wound was stitched in the hospital itself, and mupirocin plus neomycin ointment was advised. So what the patient counseling, what we have done is like to explain the patient and to reassure the patient. We have said that the chest pain is not any other due to because of your physiological symptoms, but to the drug you have taken previously without any measurements. Let's say the linezolid. It is a major historical antibiotic, so you should not take it. And we have made him to discontinue it and advise that this chest pain is normal reaction to the drug and you should not use it. And as he's a known and alcoholic, we advised him to take to not to take alcoholic during this course of antibiotics used and also until his recovery, which may leads down the recovery state of this patient. And what are the conclusions? So we have the pharmacist intervention, which made a crucial antibiotic selections and ADR optimization therapy as well. So
One
we
minute
have been
more.
following up the patient. Thank you. That's it. My presentation is over.
Thank you, Swati. And now to
Yeah.
Dr. Nagarjuna.
Swati, your intervention is very good, ma. Very
Thank
interesting
you,
to
sir.
see the case. Can you open the main slide once?
Yes, sir. Yes, sir. Which is of patient details, sir.
Main one, the title one.
This one.
Okay, this one. So you told that adverse drug reaction to linezolid drug, right?
Yeah, sir.
What conclusion you given, ma? Now tell ma. Don't share the slide. You tell me simply. What conclusion you given?
Uh, Conclusion in the sense linezolid is we know that linezolid is a last resort treatment for every antibiotic infection or for multiple drug failures, sir. So first of all, linezolid should not be advised at the initial stages itself. This is the first thing. And we also identified this patient has taken already 2 tablets of linezolid. That's what he has taken. That's what he has been advised at chest pain also. And we are taking this type of study. We are doing it who are all having irrational use of antibiotics, sir. Currently, only the linezolid was pointed out.
Okay. Your adverse drug reaction, what you told linezolid, it is good, ma. Can you say any few words about rational use of antibiotics?
Yeah, sir. We know the rational use of antibiotics, not only the rational use of antibiotics, but every drug we use a right option for the disease we have chosen. And we also have to have the benefit risk ratio when the drug is given. So let's say when the patient is coming with the urinary symptoms, frequent urinary symptoms, and we are choosing a drug Lasix, which can increase the urinary system rather than decreasing the edema he's having. So that benefit risk ratio and right choice and right time and right approach. These are all includes the rational treatment for antibiotics, sir.
Okay, you find out this adverse drug reaction, ma. Have you did any assessment scale, casualty
Yeah, sir.
assessment
We
scale?
have done Naranjo assessment scale, sir.
Okay, what the answer for Narinjo scale?
Actually, it was like fair. We have got fair report only. The patient said, I didn't feel much. I have got this much only. So we didn't consider it as a serious adverse event, but a serious drug reaction itself, sir. We have got around 5 to 10 in this scale, sir.
Okay, the last question, ma.
Yes,
As
sir.
a clinical pharmacist, how we can going to be advise the physicians or any patient side also? How you are going to be managing this ADR as a clinical pharmacist role?
Yes, yes. First of all, the ADR can be managed if the ADR occurs in the initial stages, we can avoid it by stopping the drug itself. Or else, if the drug cannot be discontinued, then we can try to taper the dose of the drug. Let's say linezolid cannot be avoided in this stage. So now we have given linezolid 500 mg means, then we can taper the dose of linezolid 250 mg. So the adverse drug reaction may lessen, and as you're tapering the dose, the serious events occurs, and finally we can stop this ADR one. First is like to discontinue, and second is to taper the dose, and third is finding a suitable alternate option. For cephalosporins, we have third generation, which is we're having a vast list of alternatives. Like that, we can find ADR's reactions.
Okay, okay, ma. Your question and answers is good. One suggestion to you.
Sir.
Whatever you shown, one suggestion to you.
Okay.
So, whatever you shown that pharmacist intervention, this case study, my suggestion is you go. Can you go for publication of this intervention? You can do
Yes,
any
sir, we
case.
are sure we are sure trying it, sir. But this is only a case report right now. So we are thinking of we can collect a list of case report where we have seen ADR due to antibiotics only,
Okay, okay,
so
ma.
that it will become a huge case study and it will reserve a huge interventional report as well, sir. So we are currently working on that.
Good ma. All the best for case report. Okay, for publication.
Thank you, sir.
Good ma. Good ma.
Thank you,
Over to
Shwati. Once again, a wonderful presentation. Yes, sir. Wonderful presentation and the presentation which copes with the theme and the crystal clear answer too. Thank you so much. And back to our order. Next participant, K. Bhavani from CVM College of Pharmacy. Slot number SYCCON or Rex S48009. K. Bhavani
Am I
from
audible
CVM
now?
College of Pharmacy. Yes, you are. You can start sharing your screen.
Yes, ma'am.
Bhavani, your screen is visible. You can start presenting. Your time starts
Okay.
now.
Good evening, everyone present over here. Myself, Bhavani, studying the fifth pharmacy in the TVM College of Pharmacy, Bellary. So now I would like to present a case on cerebral venous thrombosis, vitamin B12 deficiency, and hyperhomocystinemia. So first of all, cerebral venous thrombosis, it is a rare disorder. It is a rare form of a stroke, which is characterized by the formation of blood clot in the cerebral veins or dural sinuses. So these are the main blood vessels or pathways that drain blood from the brain and carry it back towards the heart. So, if there is a formation of a blood clot in these veins or sinuses, the flow of blood which goes towards backward, so it causes increasing in the intracranial pressure. So, if continuously increasing in the intracranial pressure, it mainly damages to the blood vessels or irritation occur to the nerves and triggers the symptoms like headache, nausea, vomiting, and seizures. Uh, Vitamin B12 deficiency, it is also called as an cobalamin deficiency, where there is a reduced levels of vitamin B12 in the body. Hyperhomocystinemia means it is an elevated levels of homocysteine in the blood. Actually, homocysteine, it is an amino acid which is majorly formed in our body during the metabolism of the methionine. This amino acid should be excreted from our body after undergoing the metabolism. So for the metabolism of the homocysteine, vitamin B12, B6, B9, which mainly acts as a cofactors, which are majorly required. So in this case, vitamin B12 deficiency has been there. So homocysteine metabolism doesn't occur. So this leads to deposition of the homocysteine in our blood and causes hyperhomocystinemia. When coming to the subjective, if a 29 years old male patient was admitted to the male medical ward with the chief complaints of headache, convulsions, frothing from the mouth and tongue bite, history of the present complaints, patient was apparently normal and then he developed headache which was intermittent of type and convulsions of 3 episodes, frothing from the mouth and tongue bite. Patient history was no history of convulsions and past medication history was nothing significant. Coming to personal history and diet history, his diet mixed, appetite is good, sleep was good, and ball bladder was regular. He is an alcoholic and smoker since 8 years, moderately built and nourished. Coming to the objective, BP was 140 by 90 mm of Hg, pulse rate 110 beats per minute, respiratory rate was 18 cycles per minute, pickle is negative. Seen as the patient was drowsy while he admitted, CVS S1 S2 positive, respiratory sounds, it is normal, per abdomen it is normal, and advise CBC, LFT, RFT, serum vitamin B12, serum homocysteine, MRI, MRB, and CT brain. While coming to the laboratory parameters, here the WBC is slightly increased because to fight against the infection. Lymphocytes is slightly decreased because of the redistribution of lymphocytes from the blood to the brain tissue. Sodium is slightly increased due to dehydration, and serum creatinine AST ALT was slightly increased due to the decreased blood flow to the liver and kidney secondary to the intracranial pressure. Other investigational reports will be vitamin B12 reduced, serum homocysteine has been increased, MRI which mainly shows cerebral venous thrombosis, that is blood clots occurred in the majorly anterior part of the brain, that is superior sagittal sinus, transverse sinus, and sigmoid sinus, and hemorrhagic infarcts are seen in the bilateral frontal lobes. CT brain which majorly shows sign of the CVT. Assessment based on the subjective evidences like headache, convulsions, and objective evidences like abnormal lab parameters and other investigational reports. The diagnosis confirmed as cerebral venous thrombosis, vitamin B12 deficiency, and hyperhomocystinemia. So, goals of therapy will be to reduce the sign and symptom, to identify and treat the underlying cause, to prevent further complication, and to improve the patient quality of life. Coming to the treatment plan, injection lorazepam, which belongs to a class of benzodiazepine, which is majorly used for the seizures, and injection levetiracetam, it is an anticonvulsant drug which reduces the release of excitatory neurotransmitters and treat the seizures. Injection phenytoin, it is an hydantoins, which is majorly used for the treatment of seizures. Injection mannitol and siraglizole, both are osmotic diuretic, which are majorly used to reduce the intracranial pressure. Injection heparin, it is an anticoagulant drug which
1 minute more.
enhances the activity of the antithrombin 3 and act as an anticoagulant. And injection thiamine, it is a water soluble vitamin. Intravenous fluid, which is given to maintain hydration. Tablet nicolamine, that is a vitamin K antagonist. Discharge medications has been given. Pharmacist intervention, no medications has been prescribed in to increase the vitamin B12 levels and decrease to homocysteine levels in the treatment chart. Without monitoring the patient has been got discharged. Coming to the lifestyle modifications, abstinence from the alcohol and cessation of the smoking is very important because these are the major risk factors for developing the CVT. Maintain a diet which is very low in the saturated fats and rich in fruits and vegetables. And regular exercise should be done in order to reduce the risk, in order to reduce the form, again triggering the CVT. Maintain adequate hydration. Because again it increases the risk. Adopt a which is rich in the vitamin B12, that is fish like salmon,
Thank you,
tuna,
Bhavani.
milk,
Your
cheese,
time's up.
reduce stress. Thank you.
Thank you. Over to Dr. Nagarjuna.
Bhavani, your oral presentation is good, ma.
Thank you, sir.
Okay, the questions are how the role of mannitol is going to be helpful in your case.
Mannitol,
How
it majorly, sir, it majorly crosses the blood-brain barrier and it reduces the intracranial pressure by moving the water from the intracellular to the vascular space, sir, like arteries and veins. Through that, the kidney, through kidney, we can that can excrete water, sir.
Okay, ma. You told that reduce stress also in lifestyle,
Yes,
right?
sir. Yes,
What are the possible reasons how we can manage the stress? What type of
like
things you can
sir, deep breathing, meditation, like listening to music, relaxation therapy, sir.
Okay, you mentioned one more drug, phenytoin also, no?
Yes, sir.
What is the adverse effects we can see from phenytoin, or any
Like
side effects?
sir, gingival hyperplasia and dizziness, drowsiness, ataxia, sir, like coordination difficulties.
Okay, one more drug you mentioned, isotrom, I think. Nicomalone, one drug you mentioned, I think.
Sir, acetrom, sir.
Tell me
Acinacumulonics.
mechanism of action of the drug.
Like it inhibits the synthesis of vitamin K dependent clotting factors in the liver, sir. By that, it acts as an anticoagulant.
Okay, one more question. You told diet rich in vitamin B12.
Sir.
What are the possible diet we can see in high rich in vitamin B12?
Like dairy products we can see, sir, like milk, cheese, yogurt, and fishes we can say, sir, like the salmon fish, tuna fish, and almonds, soy. In this, vitamin B12 is rich, sir.
Okay, the last question, ma. What are the risk factors for this? Whatever you presented case is there. What type of possible risk factors?
It is based on a non-genetic and genetic, sir. Like in non-genetic, hormonal imbalance, trauma, surgery in the head and neck region, dehydration, which mainly causes a more viscous blood, that may got chances like increase in the formation of blood clot. While going through genetic part, protein C deficiency, protein S deficiency, hyperhomocystinemia. So in this case, hyperhomocystinemia is the major cause, sir.
Okay, good, ma. Over to Jennifer.
Thank you, Bhavani. Thank you for presenting. We can stop sharing now.
Yes, ma'am.
And to our next participant, Mamata Kulkarni from SET's College of Pharmacy, slot number SYCCON RX S0010. Mamata Kulkarni from SET's College of Pharmacy, SYCCON RX S0010. Kulkarni, are you there? Okay, to our next participant, Gariboina Chenakesava Raju from SIMS College of Pharmacy. Slot number SYCCON RX S480011. Chenna Kesava Raju from SIMS College of Pharmacy. Slot number SYCCON RX S480011.
Good evening, everyone, and good evening, sir. Am I audible to everyone?
Good evening, Raju. You are audible and your screen is also visible. You can move on to your slide and start presenting.
Okay, thank you, ma'am. Now, first, I am going to present a case on this is Chanakesa Raju, studying third Pharma D in SIMS College of Pharmacy, Guntur. Now, I am going to present a case on asthma. Going to present a case, I am telling I have to give a clear information about asthma. Asthma is a chronic pulmonary disease which is caused by bronchoconstriction. Now, moving to the case, a male patient joined in a hospital at the of age 45, joined with the chief complaints of fever, cough since last 7 days, and dyspnea and shortness of breath, wheezing sounds, expectoration with yellow sputum. Coming to the past medical history, he is asthmatic and taking the medication Deriflin, which is the combination of etiofilin and theophylline, and tablet locks off and tablet Texgene. On coming to the on examination, he was conscious and coherent. Vitals were normal. BP, pulse, and respiration rate are normal. Temperature is slightly increased. Going to the lab investigations, now we have performed some tests like CBP and ESR, erythrocyte sedimentation rate. All the CBP complete blood picture was normal, and ESR is increased. Due to ESR was increased on day 1, 2, and 3, and later by using of medication it was cleared. And coming to the biochemical value, that means the biochemistry lab investigations, coming to serum creatinine, blood sugar, and blood urea are normal. And now another diagnostic test called sputum culture, which was shown positive for Staphylococcus aureus and Haemophilus influenza. And going to the another investigation, chest X-ray, which shows hyperinflation of chest. And coming to the provisional diagnosis, it was diagnosed as respiratory tract infection and bronchial asthma. Treatment. The goal for the treatment is to reduce the symptoms and give relief for the breathing. Coming to the treatment, the medication given to him was syrup ascoril, Brocostel tablet, and Furon Plus tablet, and Combimist nebulization. Coming to the pharmacist interventions, the pharmacist found that increased ESR is due to bacterial infection, and increased total WBC count and Staphylococcus and Haemophilus influenza were grown on upper respiratory tract during the sputum culture. And coming to the assessment, ESR and WBC count was increased due to infection. Presence of Staphylococcus in aureus is due to bacterial infection, and hyperinflation due to chest X-ray shows bronchial asthma. Coming to the discharge medication, syrup ascoril, tablet Brocostel, injection Furon Plus, and nebulization, Combist nebulization. Now coming to the drug monograph, ascoril. Ascoril is a mucolytic agent which used to enhance the mucociliary action. And Brocostel is the leukotriene antagonist, which is montelukast, which is used in asthma and allergies. And Ferrum plus injection. Ferrum plus injection is used for bacterial infection, which is the bactericidal cell bacteriostatic agent.
1 minute more.
Combimist nebulization, which is the combination of two drugs, salbutamol sulfate and ipratropium bromide. These two are the used for nebulization, which are bronchodilators. Coming to the patient counseling. Patient counseling reduce exposure to the allergens which trigger asthma and cover your nose while going out. Next, for patient counseling, according to the drug history, according to the drugs, put the mouthpiece in for the nebulization. Put the mouthpiece in your mouth between teeth and close your trunks. It should be cleaned with hot water, and nebulization should be done whenever necessary. And lifestyle modification, reduce the exposure to allergens, cover your nose, avoiding allergy foods, and include very food items which are healthy. Okay, thank you. Thank you for this opportunity, sir. Thank you, ma'am.
Thank you, Raju. Over to Dr. Nagarjuna.
Channakesava Raju.
Yes, sir.
Hello.
Yes, sir.
What are the risk factors, man, for asthma?
Risk factors, sir.
Yes, man. You can start.
Okay, sir. Risk factors are inflammatory mediators, sir.
Okay, man. Whether is there any cure for asthma?
No, sir. There is relief from the symptoms. That's it, sir. Complete relief from the symptoms. There is no cure, sir.
Okay. Is asthma URTI or LRTI?
Lower respiratory tract, sir.
Okay. What is the role of macrolides in asthma?
Role of macrolides.
Role of macrolides in asthma.
I don't know, sir. Sorry.
Okay. How we can preventing managing steps for asthma?
Managing, avoiding allergens and avoid allergens and food which causes symptoms that leads to asthma, sir. Exposure to cold condition should be stopped.
Okay. So the last question, man. What are the symptoms for asthma?
Symptoms, wheezing sounds are the main, sir, and sneezing, shortness of breath.
See how the shortness of breath is going to be arise in asthma patient.
Due to bronchoconstriction, sir, which is due to inflammatory mediators.
Okay, okay. Good, man.
Thank you, sir. Thank you.
Thank you, Raju. And moving on to our next participant, J. Christy Immaculate from Swami Vivekananda College of Pharmacy. Slot number SYCCON RX S4 80013. Sorry, 12. Christy Immaculate, Swami Vivekananda College of Pharmacy, slot number SYCCON RX S4 80012.
Good evening, everyone.
Good evening, Christy.
Good evening, everyone. Today, my case presentation is about psoriasis. Psoriasis is defined as a chronic inflammatory disorder of skin and joints characterized by well demarcated red papules within an overlying scale. Coming to the case, This 76 years old male obese patient was admitted in the dermatological department due to the chief complaints of redness, scaling, itching all over the skin. This is the major symptoms of psoriasis, and irregular sleep since 3 weeks, and burning in soles with swelling in both the feet, and multiple erythematous and exacerbation of itching and pain since 1 day. He had a hypertension in past 6 months, and he was taking the tablet amlodipine. It belongs to the class of calcium channel blocker of 5 mg per orally twice a day. And tablet furosemide, it belongs to the class of loop diuretics of 40 mg per orally once a day. He was a smoker and alcoholic, and he had a mixed diet, and his mother had a history of hypertension. Objective: the physical examination, he was conscious, oriented, and afebrile. The skin lesions on the abdomen, arms, legs, and scalp. At the time of physical examination, the skin appears red in color, raised, scaly, and hyperpigmented. That means the darkened spot on the skin, and severely itchy plaque of different size from 2 centimeter to 10 centimeter, both the limbs. And scales are involved, which are silverly white and moderate in amount. The systemic examination was normal, and vital signs, the blood pressure was slightly elevated because of hypertension. And coming to the laboratory investigation, the hemoglobin level was low. This may be due to the chronic inflammatory condition, and high ESR and uric acid level was high because of inflammatory condition, and skin biopsy also taken. Then assessment, based on the subjective and objective evidence, the patient was diagnosed with psoriasis. Plans on therapy: tablet acetylene of 25 mg per orally once a day for first 3 days. It belongs to the class of oral retinoid. It is used to treat psoriasis. And tablet prednisolone of 20 mg per orally twice a day for first 3 days. It belongs to the class of corticosteroid. It reduces the inflammation. And tablet for folic acid 5 mg per orally twice a day for first 3 days. And salicylic acid 5% of ointment twice a day for first 3 days. It belongs to the class of keratolytic agent, and it used to soften the skin. And tablet cetirizine of 5 mg per orally once a day for first 3 days. It belongs to the class of second generation antihistamines, and it reduces the allergic condition. And tablet amlodipine, it belongs to the class of calcium channel blocker. And injection furosemide of 20 mg IV once a day for first 3 days. It belongs to the class of loop diuretics. And discharge summary was given. And then pharmacist intervention, the drug-drug interaction, the combination of acetylene and methotrexate, there may be a risk of hepatotoxicity, so need to check the liver function test. And folic acid and methotrexate combination, it decreases the folic acid serum level, so methotrexate may result in decreased folic acid blood level. And drug alcohol interaction, the tablet cetirizine may interact with alcohol. It leads to increased risk of CNS depression. And the tablet methotrexate interacts with alcohol, which means increase in hepatotoxicity. Tablet folic acid, that will interact with alcohol, which leads to decreased folic acid serum levels. And points to physician, the lipid profile test was not done. The person is obese and also having a hypertension, but there may be chance of hyperlipidemia. There is not performed as a lipid profile test. And methotrexate may be a cause of nausea and vomiting, but the prescriber didn't give antiemetics. And efficacy monitoring parameter, the acetylene, there may be a decreased severity of lesions. And toxicity monitoring parameter also given. The acetylene, we need to check the liver function and the lipid function test. And coming to the patient counseling point, the disease-based counseling, follow the regular therapeutic regimen and regular monitoring of blood pressure, and take the bath regularly. And bathing helps to remove scales and reduce inflamed skin, and avoid overexposure to sunlight. Use sunscreen. It can protect your skin from sunlight. Use moisturizer. Drug-based counseling, the acetylene, avoid blood donate during the therapy. After 1 year of the therapy, use sunscreen at the time of therapy. And coming to the diet-based counseling, you should eat vitamin A containing food like carrot, and eat omega-3 fatty acid containing fish like sardines. It may have the anti-inflammatory effect. And it also eat take.
Thank you, Christy Immaculate. Your time is up.
Thank you, ma'am.
Thank you, and over to the judge.
Christy, it is a good presentation, ma.
Thank you, sir.
So, question is, ma, do you know about psoriatic arthritis?
Yes, sir.
What do you know about psoriatic arthritis?
Sir, it is a inflammation and swelling of the swelling in the joint, and the joint destruction may also occur in approximately 10 to 30 percentage of the people are affected by psoriatic arthritis, sir.
Okay. What is the role of methotrexate, ma? MTX. Role
Sir,
of
it is hello.
you
Sir,
can
it
carry
is
on.
an metabolite, sir. It inhibits the cell growth and proliferation, sir. It inhibits the dihydrofolate reductase enzyme, so it interferes with the impaired DNA synthesis, sir.
Okay, what are the possible etiological factors, ma, for psoriasis?
Sir, environmental factors and genetic factors, immunological factors like TNF alpha activity will be increased, or genetic factor, the HLA alleles like HLA alleles and deletion of LCE protein, sir, and environmental factors such as cold, trauma, or stress, or any other condition, and infections also may be possible of etiological factors, sir.
Yes, ma. Good, good. Name the drugs which will cause psoriasis. Name any two drugs, or at least
Sir?
one drug which will cause. At least, tell me one drug which will cause psoriasis. Drugs
Yes,
also
sir.
etiological factor for
Yes, sir.
psoriasis.
Iodides, aspirin also cause the psoriasis, sir, and botulinum A and lithium, sir.
Yes, ma. Lithium are there. So NSAIDs also it will cause. Beta blockers are there. So these are all the possible one of the rare chances of etiological factors of psoriasis, right?
Yes, sir.
So the last question, ma. What is pruritus?
Sir?
What is pruritus?
Sir, it is a
Okay, ma.
puzzling
Leave it.
that
Do
may
you,
occur.
okay. Next question, ma. What do you know about balneotherapy?
Sir?
Have you heard about balneotherapy?
Balneotherapy.
Balneotherapy.
That Soralen and UVA light.
It is nothing but as the person who are taking balneotherapy, that is nothing but bathing in water is there. It will contain different type of salts. Okay, it is going to be combined with any natural exposures are there, like sun exposure. Okay, these things you have to know more. Actually, psoriasis we will see in the balneotherapy, emollients, moisturizers are there. Okay.
Yes,
The
sir.
last, tell any two counseling points for psoriasis.
Diet based, sir.
Yeah, whatever it may be. Tell any 2 points enough.
Take vitamin A containing food like carrots, sir, and also take vitamin D containing food like egg, milk, yogurt. It is benefit for psoriasis, and also take antioxidant rich herbs or spices, and also eat vitamin omega-3 fatty acids, sir.
Okay, ma. Good. Overall presentation is nice.
Thank you, sir.
Thank you, Christy.
Thank you, ma'am.
And our next participant, B.S. Janani from Swami Vivekananda College of Pharmacy, slot number SYCCON RX S4 80013. B.S. Janani from Swami Vivekananda College of Pharmacy, slot number SYCCON RX S4 80013.
சரி ஏதோ கடகடன்னு ஆன்சர் சொன்னல இந்த நன்றி குட் பிரசன்டேஷன் பார்த்துருக்காங்க.
Christy, mute yourself.
Hello, ma'am.
Yes, Janani, you can start presenting. Your screen is visible. Can.
Good afternoon, students. Good afternoon, everyone. Today, my case presentation on asthma. Asthma is a condition in which will cause airway narrow swellings to cause difficult to breathing. The patient details: the 75 years male patient was admitted in the general medicine department due to chief complaints of fever and wheezing. The past medical history type 2 DM, past medication history tablet metformin in 500 mg. In social history, the smoker coffee 3 times daily. The family history was nil. On physical examination, conscious, oriented, and febrile. In vital signs, shows that temperature, the pressure rate, respiratory rate was found to be elevated. Laboratory investigation shows that fast random blood sugar was found to be elevated. Imaging study report, chest X-ray and CT scans. The diagnosis: the patient was diagnosed by asthma. Assessment: the patient was diagnosed with asthma. Therapeutic chart: injection SYCCON, amoxicillin plus carbonic acid, 300 mg, given route of IV, thrice a day, first 3 days. Belongs to class of beta-lactam antibiotic and plus penicillin antibiotic, and mechanism of action: inhibit the bacterial cell wall synthesis. It is used to treat the bacterial infections. Injection theophylline 4 ml, given route of IV, twice a day, first 3 days. Belongs to class of bronchodilator, and mechanism actions: smooth muscle relaxation, suppress the airway stimulant. It is used to treat the asthma and bronchitis, other lung diseases. Injection tablet pantoprazole for 40 mg, given route of orally, twice a day, first 3 days. Belongs to class of proton pump inhibitor, and mechanism actions: bind with H plus K plus ATP pump, inhibit the gastric acid secretion. It is used to treat gastric secretions. Is a tablet paracetamol, tablet paracetamol 500 mg, given route of orally, twice a day, first 3 days. Belongs to class of analgesic and antipyretic, and mechanism action: reduce the fever. Nebulizer Diolin 200 mg, given route of nostril 6 hours once, and belongs to class of bronchodilator effect, and mechanism actions: to reduce the bronchoplasma, both anticholinergic and sympathomimetic mechanisms. Nebulizer Buticide and 100 mg, given to the nostril, twice a day, first 3 days. Belongs to class of anti-inflammatory, and mechanism action is reduce the irritation and swelling in airway. Tablet metformin 500 mg, given route of class of bigonate, and mechanism actions: stimulate the release of insulin by the pancreatic cells, and the cells reduce the gastric tolerance. Discharge summary: the tablet theophylline, and tablet pantoprazole, tablet SYCCON, and tablet metformin, nebulizer budesonide. Discharge summaries. Goals of therapy: to control the asthma, to reduce the symptoms, improve the health status, to prevent the infections. Patient counseling: diet-based, disease-based, drug-based. First one's disease-based: sufficient amount of carbohydrate to take the blood sugar and normal range. Do not expose to allergen. Cover your nose and handkerchief while cough and sneezing. Do not expose to brisk walk in 15 minutes. Wash your hand regularly. Change your lifestyle modifications. Drug-based: do not expose to drug. Do not misuse the drug. The correct storage of drug. Do not take any medication with consult your doctor. Completely course of therapy: pantoprazole should be taken half an hour before the meals. Diet based: either intake the milk, egg, carrot, leaf green vegetables, and the high rich food, vitamin D. Beans, cabbage, onion should be avoided. Toxic gas. Intake turmeric milk in prepare. Always drink lukewarm water. Thank you, sir.
Thank you, Janani. You're on time. Really appreciate it. And now over to Dr. Nagarjuna.
Janani, once open treatment chart.
Here, the skin disorders in newborn. A baby was born in Government Medical College Hospital on 27/2023, and here are not only the hyperlipidemia, that there are more skin disorders, that is transient or benign, that is erythema toxicum, that is the common skin rash that mainly healthy newborns get, usually occurs in the first few.
Jennifer, can you mute that?
Yes, sir, I did, sir. You can start, sir.
Janani, here nebulizers they given nama. How the nebulizers is going to be helpful in asthma? Can you explain it?
The use of nebulizer, sir. Nebulizer budesonide levosulfonate, sir. Hello, sir.
Can you?
Sorry, Janani, you can start. Participants, please make sure your mic is muted. It's disturbing the other one. Make sure your mic is muted. And Janani, sorry for the interference. You can start.
You repeat once again, ma. Nebulizers. How it is going to be helpful in asthma?
The asthma patient is wheezing or cough, sir. So take in nebulizer in medicine, sir.
Okay, ma. One more question. What are the possible risk factors for asthma?
Yes, sir.
Tell me, what are the risk factors are there?
Allergens, drug-induced aspirin, ibuprofen, beta blockers, food allergies to causes, allergens, pollutions to duck mice.
Okay, one more thing, ma. You told mentioned about SIPMOX, right? One more drug, amoxicillin clavulanic acid. Can you explain the mechanism of that?
So amoxicillin and clavulanic acid, sir. Amoxicillin and clavulanic acid inhibit the bacterial cell wall synthesis, sir. Used to treat the bacterial infection, sir.
Okay, the last question, ma. What are the complications that will arise from asthma?
No, sir.
Okay, thank you for presenting, ma. Over to Jennifer.
Oh, thank you, Janani. You can stop sharing your screen now. Okay, to our next participant, Rajput Akashina. Sir?
How many more? One or two?
Two more, sir. Two more, sir.
Okay, carry on.
Okay, sir. The participant, Rajput Akashin Narendra Singh from Sonia Educational Trust College of Pharmacy, slot number SYCCON S480015. Rajput Akash Singh Narendra Singh from Sonia Education Trust College of Pharmacy, slot number SYCCON S480015. Akash, are you there? If present, let me know in the chat. And moving on to the next participant, Praveen Kumar from TVM College of Pharmacy, slot number SYCCON S480016. Praveen Kumar from TVM College of Pharmacy, slot number SYCCON S480016.
Yes, ma'am. Ma'am, am I audible? Hello? Hello?
Praveen, you are audible. You can start.
Okay. Let me share my screen.
Sorry guys, I got left out. You're audible, your screen is visible, you can start presenting.
Good evening, everyone. I am here to present a case on rare case known as Wernicke's encephalopathy. This Wernicke's encephalopathy is an acute neuropsychiatric disorder which arises as the result of thiamine deficiency. Generally, this Wernicke's encephalopathy was firstly described in the 1881 known as Karl Wernicke. And these Wernicke's encephalopathy causes are chronic alcohol consumption, gastric bypass surgery, stomach and colon cancer, mutation of SLC19A3 gene. This Wernicke's encephalopathy occurs generally due to the vitamin B1 deficiency due to the chronic alcohol consumption. This alcohol has the capacity to inhibit the enzyme known as thiamine diphosphokinase. That is, after the thiamine entering into the bloodstream, that thiamine needed to be converted into the thiamine diphosphate and the thiamine pyrophosphate. This alcohol he has the capacity to inhibit the enzyme known as thiamine diphosphokinase. This thiamine diphosphokinase is the enzyme which converts the thiamine into the thiamine diphosphate, is also known as thiamine pyrophosphate. Symptoms in this wernicke's encephalopathy is generally occurs with the classical trait. That classical trait known as ataxia, confusion, gait abnormality, gait and eye abnormalities. Here we can see in this picture, there is an pyruvate dehydrogenase plus TSDP, alpha ketoglutarate dehydrogenase plus thiamine diphosphate, and here trans ketolase plus thiamine diphosphate. This enzyme, it is a cofactor for the most of the metabolic pathways. So if this enzyme is not cofactor is not available, means these the pathways get affected. Ultimately, brain will be get affected. These are the patient demographic details, and this with B1 deficiency generally doesn't occur as soon as the alcohol consumption, because our body has the capacity to store the this thiamine up to 30 to 50 mg. So this wernicke's encephalopathy has to be occur, means this by B1 deficiency should be prolonged up from 4 to 6 weeks. Then only this condition may arise. Next is subjective evidences. A 33-year-old male patient admitted to the male medical ward with the chief complaints of giddiness since 15 days, drowsiness since 3 days, irrelevant talk since 5 days, and fever since 1 day, pain in abdomen, and blurring of vision. And no any medical history was present. And social history was chronic alcoholic since 15 years. When come to objective evidences, there were no any abnormality in the on examination. In the systemic examination, altered sensorium was present in the central nervous system. When move on to the advice was given as these are the advice, that is complete blood count, MRI brain, serum vitamin B12, liver function test, renal function test, CSF analysis. These were the advices, and there were no any abnormalities. The abnormal report where serum vitamin B12 is 175.5, that is it was reduced, and CSF analysis. CSF analysis, it shows complete there isn't cell type, cell count was more, means here normal cell count is 0 to 5 cells per CUMM. Here is cell count is more. It is indicating that, clearly indicating that there is an inflammation to the brain. On these subjective evidences, the diagnosis is confirmed as wernicke's encephalopathy. Planning is to reduce the signs and symptoms, to prevent the further complication, to prevent the disease progression, and to improve the quality of life. Further complication is known as, here if it is not treated well, means it may lead to the condition known as Korsakoff syndrome. That to prevent that syndrome, our planning should be, next treatment is, this is the treatment: injection ceftriaxone, third generation cephalosporin antibiotic, and injection thiamine, injection acetaminophen, and injection Vitcofol tablet doxycycline, injection dexamethasone, injection acyclovir tablet aspirin, and a tablet atorvastatin. Here there is no any pantoprazole in the treatment was involved. And the physician notes, when we move on to the day 10, day 10, the patient was discharged. These were the discharge medications. And the pharmacist intervention. Coming to the intervention part is, the intervention which I found is, the patient treatment plan doesn't include testing for vitamin B1 levels. Any B1 levels diagnostic test should be included,
1 minute more.
yes, ma'am. Such as the plasma thiamine level should be tested, and doxycycline was prescribed without a proper indication. Cognitive promoters such as acetylcholinesterase inhibitors such as rivastigmine, physostigmine, pyridostigmine can be prescribed in order to enhance the cognition. Magnesium supplementation can be initiated, because along with that cofactor which I have mentioned, thiamine diphosphate, this magnesium is also acting as a cofactor in that metabolic pathway. So magnesium supplementation can be prescribed. In the treatment plan, proton pump inhibitor was needed to be included, because there are two drugs which are known as dexamethasone as well as the aspirin. The aspirin is known as an ulcerogenic drug. It causes the GI bleeding, GI ulcerations. Also dexamethasone, when it comes to GI tract, it increases the gastric acid secretion as well as the pepsin. So in pantoprazole was needed to be prescribed in the treatment plan. No drug interaction were found. And when come to the patient counseling, all the medications should be take all the medications as prescribed, and if any unusual reaction occur, then consult the physician. Lifestyle modifications are: avoid alcohol consumption as it was worsen the condition, and have a balanced diet rich in thiamine. Consume food rich in omega-3 fatty acid, because the omega-3 fatty acids will improve the brain injury, improve the brain injury. And consume magnesium rich foods. Proper medication adherence should be there, and stress should be managed by practicing the meditation, and regular exercise needed to be done.
Well done, Praveen Kumar. Well done. Actually, I gave you 30 seconds extra because you've been holding your anxiety for the entire time. And that's why, as you're a last participant, we gave you 30 seconds extra. Really good, and you made it to the end. Over to Dr. Nagarjuna.
Praveen, the overall presentation is excellent, man. We are very much interested by seeing the case.
Thank
Almost
you, sir.
all we covered in our own presentation. Once open the main slide, title slide.
Yes, sir.
Okay, can you say any few words about Wernicke's encephalopathy? What type of research you did by collecting this case?
Yes, sir. The research I have done is one is in these patients there will be an impairment in the cognitive impairment will be present, sir.
Okay.
So to overcome thus cognition impairment, we can prescribe the acetylcholinesterase inhibitors, sir, such as rivastigmine, pisostigmine, and pyridostigmine, sir, in order to enhance the cognition, sir.
Okay.
Sir, another one is here their dexamethasone is prescribed, sir, and aspirin is also prescribed in the treatment plan, sir.
Yes, yes.
He have to increase the GI acid secretion, sir. So in treatment plan, that proton pump inhibitor was needed to be prescribed, sir, for the patient.
Okay. So, see, one more question is there. You told that injection thymine is there, no?
Yes, sir.
Can you tell me a few words about how the thymine is going to be helpful in Wernicke's encephalopathy? What role does it is going to be take place there?
Usually in a healthy individual, sir, the thiamine which is taken through the dietary supplement, sir, it will enter into the bloodstream, sir. In that bloodstream, there is an enzyme known as thiamine diphosphokinases, sir. It will convert the this thiamine into the thiamine diphosphate as well as thiamine pyrophosphate, sir. These are the active metabolite of the thiamine, sir. So in this condition, what happens means if the patient consumes the alcohol, means this alcohol has the capacity to inhibit the thiamine diphosphokinases, sir. If it is inhibited, means thiamine pyrophosphate, it is not able to get converted into active metabolite because this thiamine is needed, sir. We can see in this slide, sir. This is the glycolysis pathway and this Krebs pathway as well as the pentose pathway, sir. Here, these enzymes are dependent on the cofactor known as thiamine diphosphate, also known as thiamine pyrophosphate, sir. So this thiamine diphosphate or thiamine pyrophosphate is not present, means these all the pathways get affected, sir, and ultimately it leads to the cell death, sir, mainly in the brain, sir.
Okay. Now, once open treatment chart. See, one more drug is there. Injection Vitcofol is there, no?
Yes, sir.
That is also they started on day 3 to day 10.
Yes,
What
sir.
are the indication by giving Vitcofol?
Sir, what are the?
What are the major indication why they given Vitcofol?
Vitcofol, sir, it consists of vitamin B12, sir. Here in the laboratory test, there is a B12 deficiency, sir.
Okay.
So, consists of vitamin B12, B1 as well as B6, sir.
Okay. Why they choose an acyclovir drug on day 10?
Here acyclovir there is no proper indication, sir, because they thought here we can see cell count, sir, 50 cells per CUMM, sir. So they thought it may be any case of viral meningitis like that, sir. It is not that condition, sir, because due to the inadequate supply of glucose as well as the ATP to the brain, there is an inflammation, sir. The brain cells has undergone the condition known as apoptosis, sir.
Okay, good, good. The last question, Praveen. Can you say
Yes,
any few guidelines regarding treatment guidelines of Wernicke's encephalopathy?
sir, research suggests that as I reviewed the articles, 3 articles I have reviewed, sir. Research suggests that there is no proper treatment, sir. But thiamine supplementation should be initiated without the diagnosis, because in almost all the alcohol consumption cases, there will be a nutritional deficiency will be there, sir.
Okay. So overall presentation is excellent, Praveen. Over
Thank
to
you,
Jen.
Thank you, sir. Thank you, Praveen. It was excellent. Thank you for your wonderful participation. And you guys, with that being said, we've come to the end of this competition, case presentation competition on rare and interventional case report dermatology cases, ophthalmology case study. Excellent, appreciated, really enthusiastic participants have come today with an efficient cases. Appreciations to Aki, Tejashri, Rifa, Jason, Deepak, Yogesh, Jnanish Kumar, Bhavani, and Christy, Raju, Janani, Swati, and Praveen. Excellent, you guys. Keep your enthusiasms high. I really appreciate it and looking forward to add more things to participate in. And special thank you to our judging panel expert, Dr. Nagarjuna. Thank you so much, sir, for your patience and your scheduling time for and participating this event. You made
Yeah.
it a very good, clear
Yeah.
questions. Everything was